I wear two hats. Psych, which is the educational platform. I've been involved in education for a very, reasonably long time, since 2009 when I first set up Psych, which is, I'll give you a bit more information about that. And Vita Healthcare, so primarily a clinician, and I work in sort of the outpatient, inpatient, and the Mornington Peninsula, also just in alcohol rehabilitation and consultation liaison psychiatry. So a little bit about Psych. We started, I trained in the UK. I completed my membership in the UK, and then when I came over here, there wasn't really much in terms of education. I was doing my exams myself for the fellowship, and once I completed the fellowship, I found that there was a real need for mental health education. So that's when I set up Psych, and predominantly it was cases to help registrars get through their exams. So we've trained over 3,500 registrars, many of whom are consultants. And we take a mandatory Psych selfie at the end of the course. And generally the feedback's been very good. So that's just a snapshot of one of the events. Now, as general practitioners, of course, you play a very important role in, when you look at the mental health landscape. 2/3 of the burden of mental health is really managed by general practitioners in many of the disorders. So clearly, intervening at the primary care level is extremely important. Hence, the natural progression for Psych was to really provide the same quality education to general practitioners. Unfortunately, we've been able to do that since 2015. Survey has been a big supporter as well, so a big shout out to them as well. And we've trained over 850 GPs through the masterclass to date. We hope to, help many more. As a clinician, I work with 6 psychiatrists and 6 psychologists at Vita Healthcare on the Mornington Peninsula. So it's sort of a boutique mental health practice, a really good team. With individuals, specializing in different disorders. But as you'll see, that it's very difficult in psychiatry because diagnoses don't present in nice categories. So many of us, bounce off each other, work together to solve a problem, and that's how we're going to be thinking about mental health at the masterclass as well. We're also a fun team. Mental health can be a really challenging, group. Clinically, the mental health psychiatry patients, they often can be chronicity. There can be lots of psychosocial issues, and it's important that as a team, there's always that peer support.
Excuse me, do you look after public patients as well?
Yeah. So so the service that we work closely with is Peninsula Health. So often what happens is we look at ourselves as an important cog, where patients after their discharge, particularly, because most patients from the public mental health services are discharged, inpatients generally on a depot or things like that, and often those individuals will be taken up by the private services and general practitioners, of course. So really we look at providing that interim care between sort of the very unwell that will go to public and the general practitioner side where they're managing the primary care aspect. So the next aspect, I guess, as to why how I'm going to try to convince you is social proof, the other principle of persuasion. And this is some of the feedback from your colleagues, and we get a range of speakers to sort of contribute to provide their insights at the GP masterclasses. So we do, like for example, Carl is a pain physician, Josh Geffen in Brisbane, he works with, he's got a special interest in ADHD, treatment-resistant depression, ECT, etc. And these are some of the other sort of feedback sort of slides that we've got, but we've got lots of really good feedback. So that's another way of convincing you. But I guess what I'm going to try to do is, besides social proof, authority bias, all of those things, I think the way I'm going to try to convince you to come to the event is really just focusing, giving you a glimpse of what actually happens at the event, the way we think about mental health at the event, and why GPs find it very useful. So a little bit about what the GP Mental Health Skills Masterclass is. It's accredited by the RACGP and ACRIM. 40 points, category 1 points. And what's covered at the masterclass is we first look at, of course, the risk aspect. Now, the way we look at risk is very, very different. So this is not just about asking about self-harm and suicidal ideation, because the individuals with the risk presentation are often covert. So individuals that are at high risk of suicide are very unlikely to often come and say that they are going to hurt themselves, etc. So it's really about how do we focus on the risk factors in order to determine a risk profile. For example, a certain kind of depression, if male sex above the age of 45 with melancholic depression, that's the risk group that's very, very significant. Individuals with akathisia post first episode psychosis on a depot antipsychotic medication, that's a group that's high risk. But many of these individuals very unlikely to come and say, I'm suicidal. And that's the sort of high index of suspicion that's required. And that's the way we sort of focus on risk at the masterclass. The next bit is identifying and recognizing common mental disorders. Now, the way we talk about mental health disorders isn't in the DSM-5 sort of categorical manner, because we'll see that cases just don't present like that. There is a huge degree of overlap, and unless there is a different way of thinking, it's very difficult to solve those issues. Because traditionally what happens is we tend to use heuristics as human beings. We tend to narrow everything down into asking the question, what's the diagnosis? And the diagnosis makes us feel comfortable. It gives us a clear plan saying, well, it's depression, therefore let me try this medication. But it's too simple. It's important to simplify it, but making it simple is actually, it just defeats the purpose. So the way we look at solving the problem is to come up with a formulation which fits in very well with the GP mental health care plan. In fact, the two-page GP mental health care plan is ideally structured for it. So we actually go through cases, filling up those plans and give you a completely different way of thinking that fits in that 15-minute interview. The next one is identifying presentation to specialist care. When is it important to think about a psychiatrist? Even for me, I generally, if a person's not getting better in 6 months, the way I would expect them to, I'll usually go for a second opinion, a fresh look, because there's often a few things that potentially can be missed, and that's why getting that other head is important, or a few other heads is important. We then look at a biopsychosocial formulation. Now, I'll show you the slide of formulation and how we traditionally should think about a formulation to solve a problem, because it leads to a very, very clear management plan. We then complete a GP mental health treatment plan, and I focus on the basic psychopharmacology, so it allows us to target specific medications for specific symptoms. So we deconstruct depression, we deconstruct ADHD, we deconstruct schizophrenia, as opposed to sort of reducing it to a single diagnosis. So what does a GP mental health skills masterclass contain? It's not a single, although it's advertised as a single event, it's very much a process. So what we do is there's pre-course material. We give you access to psychinterview.com. Psychinterview.com is a tool that's used by registrars for their OSCE practice. It consists of 31 videos, that's about 8 to 15-minute videos that cover assessments, cover psychoeducation, about the important aspects in primary care. So that's something that is very useful from a practical perspective. So we provide that. You have a booklet. That's a booklet that a lot of GPs find very, very useful. I had the course last weekend in Coffs Harbour, and one of them said, this booklet is gold. And a lot of registrars also tend to use it, consultants tend to use it now, because it consists of interviewing skills, and it consists of just summarized, distilled, evidence-based aspects that you need to know, or that will rather help in clinical practice. We go through interactive quiz and cases. So the latter half of the day, from 1:30 onwards, is really interactive cases. So I give you the framework in the morning from 9 to 12:30, and then you apply that framework to solve cases, and we go through a range of cases depending on the day and the specialists involved. And of course, after that, we've got online access as well with other material, which I'll show you. Now, the most common question that I tend to get asked as a psychiatrist is, what kind of patients do I see? And it's a very, very difficult question to answer. And I guess general practitioners often, ask that question in order to think, okay, well, what kind of patients do I refer? But the reason why it's such a difficult question to answer is because patients really don't present in nice categories. So I won't be doing justice if I say I see people with depression, because when we think about a spectrum, it's really a mood disorder spectrum. People might start off with depression, at the age of 15, but that might be actually a bipolar correlate. And at the age of 25, when the risk factor kicks in, or when the switch occurs for bipolar, at 25, that diagnosis may change to bipolar. So it's about understanding what are the risk factors and what is the genesis of each condition that allows us to target treatment. So let's take a couple of examples, and let's think about a framework in order to solve a particular issue. So this is a GP referral. I'll read it out. I've taken a screenshot exactly as it is on the referral. So it says, "Thank you for seeing Mr. X, age 72 years, for possible admission. He recently was unexpectedly, inverted commas, retired from his teaching job 3 weeks ago and has since had a dramatic decline in function with depression, laced with ideas of catastrophe and a gradual worsening of mobility and self-care. He's married, his wife is a teacher also and working. During the day while she's at work, he's become so frozen that he's not feeding himself or drinking. He complains his throat is dry and closing over. He literally stops mid-task and can stay there for hours. This is all very unlike him. He has developed a slow, unsteady, shuffling gait, staring blank impression, and paucity of speech." And this is obviously when you're reading that particular case, this is the extreme end of the spectrum. But when one solves this particular case, any other presentation becomes a lot easier to treat, and that's why we tend to use this case at the GP Masterclass as well. Now, I'll give you another case, and the reason why I'm doing this is because it sets a really good framework to think about, how to use a particular framework, how to use the formulation framework. So this is another case that I saw about 3 weeks ago. "Many thanks for seeing Mr. X, age 48 years, with treatment-resistant depression that has only had partial response to TMS therapy and valdoxan antidepressant. He has a long history of cyclothymia, which has been labeled by various psychiatrists as major depression with OCD traits. However, I'd like to clarify this diagnosis. Mr. X and I have discussed his further treatment at length, and both wonder whether his partial response may in fact be due to the fact that he has a trauma history that requires further diagnosis, and we would really appreciate a guidance on a long-term management, please. Mr. X is very despondent, and he feels that he's had only at most 20% improvement at times, and has quite frequent ongoing intrusive thoughts, ruminations, and suicidal ideations. He has an incredibly supportive wife who is going away overseas for a few weeks, and I wonder if this is contributing to his decline in mood. He's an associate professor at RMIT. Now, these are the specific symptoms, and it just, when we're reading these things, there are specific clues there that tell us what part of the brain's involved, and it helps us target specific things. So in this case, for example, it says RTMS didn't work, valdoxan didn't work. The reason, it's not that they're not working, it's because one part of the brain's not addressed. And that's really, picking that aspect is absolutely crucial in psychiatry. So major depression with worsening symptoms over the last 6 months, frequent suicidal ideation, and persistent intrusive negative thoughts constantly whirring around in his head. Associated with low mood, poor motivation, disturbed sleep, and early morning waking. Feelings of worthlessness and guilt, anhedonia, depressive episodes since teenager, strong family history of depression, poor response to multiple antidepressants, trialed Effexor, Lexapro at high doses, which did help with the intrusive thoughts, but had no effect on low mood and energy. And that's a great clue. I'm going to show you the brain. The reason why I'm doing this is because, hoping that you keep this particular case in mind and the previous one, and when we look at the brain, it will all make sense. And in fact, worsened his self-care with elevation of destructive patterns of increased alcohol and marijuana use. Feels better when he uses marijuana and alcohol. He denies any psychotic or manic episodes and further questioning. He's an excellent insight and is working really hard on self-care with regular exercise and yoga. He's seeing a private psychologist. And it repeats again, you can see here constant negative intrusive thoughts with frequent suicidal ideation, protective relationship, and significant feelings of worthlessness and imposter syndrome. He's also trialing fish oil, turmeric, hydrozinc, B6, vitamin D, So you can see here, someone who's really frustrated, trying a lot of things, just isn't getting better. So, how do we think about, any psychiatric presentation? The important thing is, the traditional way is what's the diagnosis, but that really doesn't help us. The way that allows us to deconstruct the issue is a hierarchy. And when we think about psychiatric diagnoses, they're actually arranged in a hierarchy. We start off with organic. So, think about both these cases. So the hierarchy is organic spectrum, and we think in terms of spectrum. Don't worry about the diagnosis. Because if you get 5 psychiatrists in the room, you'll have 10 diagnoses for the previous 2 cases. But reliably, we will find that those 10 diagnoses will lie in the right spectrum. So that's where the reliability is. But the names can change. So the hierarchy is organic, substance use spectrum, psychotic spectrum, affective spectrum, anxiety, OCD, PTSD or trauma-related disorders and eating disorders, and finally personality. Now, what's the significance of the spectrum? It means that when a person doesn't respond to a particular treatment, you look higher up the spectrum and you look lower down, because that's where the clues arise. So take the first example. The first example, this is someone who's shuffling, paucity of speech, clearly was not eating, was not drinking, lost a lot of weight. And if you go through the spectrum, clearly I'm going to think about organic, right? And you might have a few thoughts here. You might have thought of Parkinson's, you might have thought, could it be a stroke? So clearly leads to a management plan, helps you think, do I need an MRI? Or what about, the blood tests, etc., electrolyte disturbances, etc., etc. Next, substance use disorder. It gives you a quick way of evaluating, okay, well, are substances involved? The next one, psychotic spectrum. Now, this is where depression can pose a real problem, because when we think about psychosis, we traditionally think of hallucinations. But psychosis in the clinical sense is really the limbic system. The limbic system or the temporal limbic system situated here, as opposed to the front part of the brain. Now, every single psychiatric disorder, except Alzheimer's, involves the front part and the limbic system, every single one. And the part of the brain that's going to give you the most trouble in clinical practice is the primitive part of the brain, which is the limbic system, because that is never addressed by any antidepressant. So the and the pathway specifically is the mesolimbic pathway, which is really involved in psychosis. But it goes through an entire spectrum. So say, for example, so the most extreme form is when someone takes IV amphetamine, it basically releases severe dopamine in that mesolimbic pathway. But on a milder level, it presents as anxiety, restlessness, agitation. And as it becomes more and more, you start getting ruminations, intrusive thoughts. You start getting overvalued ideation, which means all-consuming thoughts. And then the last step is delusions. So you can see even in the second example, where the person wasn't responding to just valdoxan, right? It's because valdoxan will help with the front part of the brain. In fact, it's very good to help push dopamine in the front part of the brain. But the limbic system isn't addressed. And there are only 3 ways in which the limbic system is addressed. You can see the patient was self-medicating and doing it himself. Alcohol and cannabis is one of the most effective ways of reducing mesolimbic dopamine. But the other 3 ways from a medication point of view is you've got at the lower level benzodiazepines, at a level just above is mood stabilizers, anti-epileptic mood stabilizers, and of course at the most severe level or the most significant way of reducing mesolimbic dopamine is antipsychotic medication or low-dose antipsychotic medication. So you can see that in both the cases, and obviously in the second one we haven't gone into much more detail, but that's the sort of case that we tend to do. And it's the recognition or the question that, are there intrusive thoughts? Is there any evidence of psychosis? But not in the traditional sense, not in the sense of just hallucinations or delusions. Because in primary care and private practice, the most common presentation of psychosis is agitation. And if you look at the Black Dog Institute, there's a statement that clearly states, if agitation is present, assume psychosis, because agitation is one of the lower forms of increased mesolimbic dopamine, and it responds really, really well to just a low-dose antipsychotic medication. So that's a really good way of thinking about a hierarchy in terms of solving the problem. And of course, the next one is affective spectrum. So affective spectrum is basically a mood disorder spectrum. You're asking, am I looking at a bipolar trait or unipolar trait, which is completely different from bipolar disorder. So in the second example and in the first example, there are actually elements of bipolarity there. What does bipolarity mean? Two poles involved, limbic system and the front part of the brain, because that's what happens in bipolar disorder. And then, of course, is there trauma, any of the other bits, or personality? And the important aspect is we can't make a diagnosis of personality disorder or personality elements if we've got lots happening here. So it gives you in about 10 minutes a really quick way of excluding things, which is really what the Sherlock Holmes way of solving a problem is that when you eliminate the impossible, what must remain must be as close to the truth as possible. In psychiatry, a diagnosis is always provisional. So the first time I'm seeing a patient, I probably have about a 60% probability of getting a really accurate diagnosis. The only time I truly know that I was right is when the person's better. Because in hindsight, I can look and see what I've done and therefore fit my particular hypothesis and say, well, that was the most likely diagnosis. So the potential diagnosis in both those cases could be major depressive disorder with mixed features, or also known as a mixed affective state, also known as bipolar depression, also known as agitated depression, also known as psychotic depression. So you can see that the names don't matter, but it's basically telling in both those cases the spectrum involved. If organics ruled out and if substance use ruled out, it's psychotic spectrum and affective spectrum. Therefore, the kind of treatments that are required is for the affective spectrum, depression, I'll need antidepressants, and for the psychotic spectrum, which is mesolimbic, increased dopamine, I'm going to need to reduce that dopamine in the limbic system, and that I come up with a different group of medications. So these patients, and it reflects the guidelines, they will require augmentation therapy. They will just not get better without augmentation therapy. And you can see that's what was happening. They tried Lexapro, they tried venlafaxine, they tried valdoxan, and the issue is all these antidepressants weren't being helped. These antidepressants need help by reducing the dopamine. Limbic system is a very powerful part of the brain, and agitation in that part of the brain just can't be managed through an antidepressant. And then, once we think about the diagnostic spectrum, then we've got to think about what's the foundation of the individual. Because the foundation of the individual allows us to modify or work on modifiable factors. So the foundation gives us a couple of things. It tells us what might I be dealing with. So for example, the first patient, the 72-year-old, his daughter had actually a manic episode during that presentation. That's telling me genes, which is really here, the genetic predisposition. So that's telling me that there's a bipolar trait. In fact, the presentation is telling me a bipolar trait anyways. But these are the kind of things that we delve into a lot more detail at the masterclass. If there's head injury, if there's epilepsy, every single factor there gives me a clue as to what might be going on. So for example, if epilepsy is there, the moment someone with depression has epilepsy, it's a completely different presentation to someone with depression without epilepsy. Because epilepsy tells me, temporal lobe involvement can present with symptoms of depression. Anti-epileptics can increase the rates of depression or can present with depressive symptoms like Keppra, levetiracetam. Or certain antidepressants can reduce the seizure threshold. Or forced normalization, when the EEG normalizes, depressive symptoms are unmasked. Or it could be just a confounding factor. So there's 5 different hypotheses to take into account. For example, vascular features. So they might have diabetes or hypertension. The presence of one vascular feature tells me that this is more likely to be a dopaminergic depression. It's more likely to involve the subcortical or basal ganglia areas. It's more likely to present with cognitive issues. It's more likely to present with treatment resistance. So a single factor really shapes the entire presentation. We think about biological, we then think about psychological. The presence of attachment difficulties or trauma during childhood shapes a completely different individual because trauma results in a completely different neurobiological presentation. And childhood trauma is different from PTSD type trauma with a single event. So these are really important factors that when we take them into account, we come up with a different hypothesis. Social models. Social models, of course, we think, who else can be involved? And of course, we think about diet and lifestyle. So when we think about an individual presenting with a psychiatric issue, we think about a spectrum, and then we think about what's the foundation. And then we try to work on the specific foundation, what's modifiable here. And you can see these permutations and combinations is basically what makes a psychiatric disorder. And this is exactly how we try to solve a problem and what we put down in the GP mental health care plan as well. It gives you a much more comprehensive overview of the individual. So, a few things, for example, in organic. So if I was looking at an organic spectrum, I could do a simple test like this. So this was a lady that presented to me for second opinion for ECT when I was working in the public system. Resistant depression, 8 different antidepressants, augmentation with antipsychotic medication, and I go through the hierarchy, right? Organic, psychotic spectrum, substance use, etc. So one of the tests I tend to use is this Luria 3-step test. It tests the frontal lobe. As I mentioned, the key parts of the brain that I'm examining always in every psychiatric disorder is the front part of the brain and the limbic system. The limbic system I can't really do by physical examination. It's through the mental, agitation and physical agitation. But this is a really good test. It's Luria 3-step. I basically say copy me. It's fist edge palm, but I don't say fist edge palm, otherwise they'll remember it. I just ask them to copy it. We're going to have someone to press. Do you mind just going? Yeah. Might just press it. So it's moved forward. Yeah. So you can see the 3 steps. She's not.
So it's 3 steps.
And despite obviously showing her the 3 steps, she was unable to do it. And you can see there's a mild tremor as well. In psychiatry, these are some of the things that can potentially just hint towards subcortical involvement. Now, on its own, it's fine. But when in the presence of depression, I'm asking myself, is subcortical areas involved? Now, I was expecting, I did a neurological examination. Rhombox was very, very off. She also had unilateral tinnitus at the same time. Now, clearly that tells me this is out of proportion. She's a nurse, 52-year-old. I'm wondering, what's happening. There were some cognitive deficits as well. So clearly the step was to consider an MRI before going ahead with ECT for resistant depression. I was expecting vascular kind of insults, which is really, when I talk about insults, they're really in psychiatry, they're white matter hyperintensities. But what we found was a glioblastoma, a unilateral temporal outlier, complete outlier, but it just shows how the spectrum, or thinking along the spectrum, can help pick up aspects. So that was a complete outlier. This is another case similarly going through the hierarchy. This is someone who presented to me with depression, again in her 50s, with treatment-resistant depression and cognitive deficits, was planning to go back to work, and very severe history of bipolar disorder in her family, in her father. And you can see the frontal lobe atrophy there, right? Now, what this tells me, I've known her for about 5 years now. Now, what this tells me is that the illness is very likely to be progressive if there are repeated stresses that are going on, right? So it just prognostically tells me that from a medication perspective, I'm going to need to be a little bit more aggressive if she does have relapses, because particularly if she presents, she's likely to present with a very severe melancholic depression, and therefore will require lots more dopamine in the frontal lobe. Because frontal lobe is purely, prefrontal cortex is all dopamine and noradrenaline. Those are the 2 main things, right? And that's the part of the brain also involved in ADHD. So for her, for example, I've got to think about dopaminergic antidepressants, and we'll talk about that in a second. But interestingly, because the frontal lobe is involved, she's likely to have manic episodes as well. She's at risk of that. And clearly in her case, she did have a manic episode. She's on a combination of lithium plus valproate plus agomelatine, 50 milligrams, and a small dose of lurasidone for agitation. And she's been stable for over 2 years. She had alcohol issues as well, but she's been stable, despite the fact that her husband had a severe accident, and she's now a carer for him because he's got quadriplegia. So a really tragic story, but despite that, she's coping really, really well. But the key is improving the brain's ability to cope with stress. And there's one part of the brain that allows you to do that, that's the frontal lobe. And it's dopamine, noradrenaline. Often what happens, we tend to fall short of how much dopamine that we tend to push in the brain. And that's where obviously specialist input does come in. Those are the white matter hyperintensities that we tend to see. For a neurologist, they're non-specific, not that significant, but we often need more. That's the brain scan of the individual, the 72-year-old that I showed. Lots of periventricular white matter hyperintensities. So I'm not surprised that he presented with that sort of presentation. But he responded within 6 weeks with a combination, which I'll talk about. That's clock drawing, that's the other test I use. So draw a circle, imaginative clock, point the arrows to 10 past 11. And that's clearly abnormal. So these are some of the organic tests when you're thinking about the spectrum. How much time have we got, Steve?
Only 10 more minutes.
Yeah, 10 more. So this is basically how we'll be looking at depression. So when we look at depression, in that particular question, I'm asking myself, is the patient not responding because of 2 reasons? There are 2 reasons why a patient with depression will not respond. One is we're treating a milder form of depression, or we're thinking it's a milder form of depression. In other words, we've missed a dopaminergic depression. A dopaminergic depression involves this front part of the brain. That's one reason, and that's the melancholic depression. There's not enough dopamine here. The second reason why patients with depression don't respond is because their limbic system is overactive, right? And that's the bipolar trait. Those are the most common steps that I take, and those are the steps I believe that can very much be taken on in primary care because the responses are dramatic and it's a very satisfying condition to treat as well. But those are the most common steps I take. Introduction of a mood stabilizer or using a dopaminergic antidepressant or augmentation. So this is how it looks, and you can see that in the front part of the brain, a melancholic depression, a dopaminergic depression is very different, presents with mental fatigue, guilt, suicidality, worthlessness, front part of the brain. Whilst the serotonergic depression is the milder form of depression presented with low mood and anxiety. They do not have anhedonia, interest and pleasure. The hedonic drive is dopamine, noradrenaline in the front part of the brain. The moment you have anhedonia, intrusive thoughts, poor concentration, mental fatigue, you're looking at dopaminergic depression. So, I'll probably skip through this just because I'm mindful of time. So, and that's why it becomes important to recognize what are the kinds of medication that we've got. And SSRI is really just looking at the serotonergic part. Sure, as you go up, you get a little bit of dopamine, right? But very unlikely to treat a melancholic depression. So, mirtazapine is your other option. Now, mirtazapine is dual. At 30 milligrams, you're getting serotonin antagonism, so it works well for anxiety, treatment sexual dysfunction, but you're not getting dopamine. If you want dopamine with mirtazapine, you've got to go to 45 and 60, right? Because it works the opposite of clonidine, pushes dopamine in the frontal lobe. SNRIs give you dopamine through the noradrenaline, SNRI, the NRI bit. But the issue is the serotonin. Serotonin has an inhibitory effect on frontal dopamine. That's why you get emotional blunting, right? Because it actually reduces frontal dopamine. And so people will say, I stopped crying, but I don't feel anything. So SNRIs can do the same. But they're reasonable to push dopamine in the front part of the brain. Valdoxan, agomelatine. This is a useful augmentation tool or first-line tool for dopamine. The advantage of this, the way I look at agomelatine is that it's mirtazapine without the weight gain. It provides M1, M2 agonism and the 5-HT2 antagonism that it has. So remember I said that serotonin blocks frontal dopamine. So when you increase serotonin, it blocks frontal dopamine. Agomelatine does the opposite. It blocks the serotonin receptor, 5-HT2, and therefore pushes dopamine in the frontal lobe. So what I tend to do is most of the times the patients that I get are often started on an SSRI or an SNRI. And if I've picked up their melancholic depression, this is one of my medications that I use a lot to augment. I don't have to worry about serotonin syndrome because I can add it with practically any of that to test the hypothesis of melancholic depression without worrying about serotonin syndrome. The only medication where you've got to be cautious about introducing it is fluvoxamine because it's a CYP1A2 inhibitor. Yeah.
Do you add the valdoxone to the Effectual?
Absolutely. So in the first patient, the first patient that I showed you, the 72-year-old, now that will respond very well to ECT. That's psychotic depression. That is a very severe, almost catatonic depression. But this is a patient who was a German teacher, family said we don't want ECT. I admitted him to a private hospital for 6 weeks, and what I did was the following. The first thing is he was a citalopram 20, not going to work. SSRI is just not going to work in that presentation. Shifted him very quickly to dexvenlafaxine. And the reason I did that is because I know this presentation is going to require augmentation strategy. It will require 2 antidepressants. There's just no way, and particularly after looking at the MRI. So I started him on dexvenlafaxine plus a small dose of an antipsychotic because that's going to be required. The reason why antipsychotic was introduced is because he had psychotic features. Family gave a list of things saying he thought food was raw, therefore was not eating. Cars had run out of oil. These are nihilistic delusions. So in terms of the depression side of things, or pushing dopamine in the frontal lobe, dexvenlafaxine was started very quickly up to 150, monitored the sodium, and then added valdoxan for the dopamine, right? In the second case, you can see the valdoxan's at 50. All I need to do is to treat the limbic system and allow valdoxan to work and reduce the intrusive thoughts by adding a low dose of an antipsychotic medication. So there are 2 different presentations by thinking about the limbic system and the front part of the brain. But to answer your question, yes, you add in valdoxan or agomelatine as an augmentation strategy when you pick up melancholic depression. But what's really important is this: always look at the limbic system first. Because if the limbic system is activated and you add in an antidepressant, you could worsen. So that's the main thing. This is why people can come up with, so that second patient presented with lockjaw, agitation, when he was started on Effectual. And those are clues towards bipolar traits. But these are the kind of things we go into a lot more detail. Obviously, it's difficult to cover some of this, but agomelatine can act as a very good augmentation strategy. So for me, 2 augmentation strategies: mirtazapine and agomelatine. Okay. The only drawback of mirtazapine is the weight gain. So I tend to use agomelatine. Agomelatin's drawback is the cost and monitor liver functions. But usually, liver functions you don't have to stop unless it goes 3 times. Okay, and vortioxetine augmentation really can't be considered or not recommended, mainly because it's a serotonin modulator, and if you augment it with anything else, the risk of serotonin syndrome exists. So more in the college guidelines, it's mentioned second line for pro-cognitive effects. And of course, important to think about estrogen and thyroid. Okay, so I guess I'll leave you with, and a lot of what I've talked about. I'm hoping, that I've convinced you that it would be worth coming to the GP Masterclass. But there's lots of other stuff that can be, we've set up the Psych Scene Hub. There's so much more that you can already read. Everything that I've talked about is there in the hub. And I might just give you a glimpse. So if we just play the video, so this is what you can actually do. So psychscenehub.com. And we've arranged everything in a hierarchy. This is the hierarchy I talked about. So you can actually put stuff in the search box. So for example, depression. And you can see all the articles and videos on depression. And they're 10-minute reads. So TMS, RANSAP guidelines. So these are the RANSAP guidelines. So this is the Cipriani study, for example. It gives you mechanisms of action of all antidepressants. So if you wanted to go to a specific antidepressant, you can see a specific antidepressant. But they're all short reads. So, probably higher bedtime reading maybe. And then we've arranged everything in a hierarchy, as you can see: organic, substance use, mood disorder, anxiety, developmental, all of those. So I'll skip this to the next one, and you can see some of the videos as well. So again, you can listen to the videos. Some of them are password protected, so feel free to just send us an email, and we can share that with you. So that's really it for me. I'm hoping that I can see you at the GP masterclass where we can solve a lot more cases together and really make a difference to patients, because these are cases that are actually quite easy to treat. So that patient, the first patient that would normally go down the path of ECT, he's completely well with just a common. It usually requires 3 medications: 2 antidepressants, really dopaminergic, and 1 low-dose antipsychotic. That's, and I've got maybe 10, 15 cases like this. What often tends to happen is that 1 extra step is missed, which is that second dopamine antidepressant, or the limbic system isn't taken care of. Yeah.
What's wrong with psychotic choice?
The antipsychotic, that's of course a whole discussion. So for example, we've got antihistaminergic antipsychotics, and those are the ways of thinking about it. The ones with antihistaminergic give you sedation, but weight gain. And you've got non-antihistaminergic, which can give you a little bit of activation, but no weight gain, right? So it's very much a choice. So for example, you want, so nowadays what guidelines have suggested is start off with a metabolically friendly one. So your choices are lurasidone, Latuda, aripiprazole, or brexpiprazole. Those are the 3 to consider. Acenapine as well, but it has bad taste and it needs to be taken, half an hour before food and all of those things. And this is the art of introduction as well. So say for example, I wanted sedation because they're agitated, and I chose a metabolically friendly one, and I chose say lurasidone or Latuda, I would add a small dose of clonazepam, because with lurasidone on its own, I might not get sedation, if that makes sense. If I want sedation, so for example, in that patient who was not eating and drinking, I want to increase appetite, and I want sedation, I might actually go down the path of low-dose olanzapine. So it's very much a targeted approach by thinking about what receptors are involved and using the mechanisms to treat that specific condition. Yeah. But we'll be discussing this in a lot more detail because it'll make sense. Important heuristics that will be applicable to your practice. Yeah.
What do you think of the new genomic testing to better inform prescribing choices?
Yeah, so pharmacogenetic testing, so there's a few articles and lectures on there. Pharmacogenetic testing is useful in certain cases. I think it's marketed incorrectly to say that it will help you choose the right antidepressant, because it doesn't. The reason is most of them contain the CYP enzymes, which is the liver enzymes. How much, it doesn't help us address receptor sensitivity. So it doesn't tell us how much is going to go through a blood-brain barrier, although CNS dose, for example, does have some of the blood-brain barrier genes. Where it's useful is if patients are sensitive to antidepressants or antipsychotics. Second, if you feel that they're at an adequate dose and not responding, they might be fast metabolizers. That's when it's useful. But to think about pharmacogenomic testing giving you clear answers, my opinion is no. It's a useful tool though, if they're not responding, to see whether they're metabolizing things quickly or slowly.
I'm sorry, we're going to take that in person immediately after. We've got 5 minutes to get to stream 1 or stream 2 or stream 3.
Thank you. Hope to see you. Talk to the show.
Well, just one more moment. I couldn't help but notice how many photos have been taken of single slides. So that signaled to me that he's piqued your interest, and we will see you on October 12th. If I'm right, you share that sentiment, if you could share that sentiment in turn with your friends and colleagues, recommend to them to attend on the 12th of October as well, that would be greatly appreciated. We booked a room at the Hyatt, I think it is, I could be mistaken, that would host 50. It would be great if we could get 50 doctors from the Westvic PHM catchment area on the 12th of October.
Yeah, and we make sure that we get your limbic systems activated with some great food as well.
Thank you very much.